I'm going to now introduce Jason, Dr. Nasser, who's our motility fellow. He's going to talk about small intestinal bacterial overgrowth, and we're very grateful to have him in our clinic, and I see him every Tuesday, and he's a tremendous mind in terms of what we're doing at the center, and I hope you'll enjoy his lecture next.
Hello, everyone. So that will be a very challenging talk to come after, but fortunately for me, based on everybody else's talks, this talk should come more of a synthesis of everything you've heard so far today. So by the end of this talk, ideally, I would want you to be able to really identify and define SIBO, and for you to recognize the symptoms that can be seen with SIBO and be comfortable with that, and also be comfortable with what predisposes you to have SIBO. And then on the second part, understand how we diagnose SIBO, and then how we treat SIBO, and maybe some of the things that can be done to prevent it from coming again. So what is SIBO? First, what is normal, and where does food go? And as you heard from Dr. Azai's talk, food goes from the mouth through the gut, and specifically from the stomach to the small intestine to the large intestine. And then what is the normal gut flora? As was mentioned before, the highest concentration that is very normal is in the colon. And that's where a lot of the normal digestion by the microbiota happens. But unlike our colon, the small bowel is relatively sterile. So here you can see that the colon has maybe 1 trillion bacteria per ml. The mouth has 1 billion per ml, while the small bowel should only have 1,000 per ml. So it's relatively sterile and has very little bacteria within it. So what is SIBO? SIBO stands for small intestinal bacterial overgrowth. It's the dislocation of the bacteria from the colon, where they normally should exist in high concentrations, and where they migrate up towards the small intestine. In reality, what I would like to highlight is that it's not really an infection. You know, when you get food poisoning, get salmonella, that's an infection. The bug is sort of maybe trying to hurt you. In SIBO, the bugs are not trying to hurt you. They're not secreting a specific toxin that's mediating the symptoms. They're just trying to grow in and of themselves, but coincidentally, they cause symptoms. And this growth is abnormal. And why is it abnormal? How is it abnormal? It's abnormal in its quantity. So the bacteria proliferate to very high numbers. That's one. Two, they're in the wrong location, right? They're in the small intestine. That's where they're proliferating. And the small intestine is narrower in diameter, maybe more sensitive than the colon. And then finally, in wrong proportions. And as Dr. Pimentel alluded to, especially our lab has recently, maybe even not necessarily just recently, has identified exactly what bacteria contribute to this asymmetric growth. And they are specifically E. coli and Klebsiella, both Klebsiella pneumonia and Klebsiella aerogenes. And so it is the asymmetric growth of these bacteria that just proliferate and get too comfortable that causes symptoms. So don't think of it in terms of good bacteria, bad bacteria. It really is just some bacteria that are growing way too much in the wrong place, and they produce the gases that you've heard about today and that I will address in a bit. So on the other hand, what is IMO? Because you've heard that abbreviation. It is the intestinal methanogen overgrowth. So methanogens are not technically bacteria, and this gets a bit technical and may seem semantic, but it does have consequences, as you've heard about, how we treat it and what symptoms it comes with. And Koka Yip will be speaking about this in details. But also, it is a dysbiosis. It's not an infection. And what is SIFO, small intestinal fungal overgrowth? Similarly, this part of the tree of life can proliferate too much in the small bowel, and we think that it has a similar presentation to SIBO, but it is different in how we diagnose it, and I'll address that in a bit. But again, it's a dysbiosis. It's not when you have fungus in your blood and you're extremely ill. It's just dysbiosis. It's overgrowth of fungus within your gut. They're just trying to live their best life, but that is inconvenient to us in a way. So what are the symptoms that are associated with SIBO, SIFO, and EMO? I will note that none of them are 100% present. So we can't say, oh, if you're not bloated, you don't have this. Oh, if you don't have diarrhea, you can't have this. Patients come into our clinic with a mixture of these symptoms. You can have abdominal distension, which is when you see your belly sort of bloated, or you can visibly see it descended. And then bloating is more so of a subjective feeling. After you finish a meal and you just subjectively feel like you're bloated. You can have diarrhea or urgency, which is more common with hydrogen predominant and hydrogen sulfide predominant bacteria, which I'll address again in a bit. And then constipation, which is more common in EMO. You can have nausea, but vomiting is not a typical aspect of SIBO. You can have abdominal discomfort, abdominal pain, early satiety. You eat a meal that's a small meal and you get full early on. That can be a lot of things, but that can be seen in SIBO. And then fatigue. We get a lot of patients who are just lethargic, fatigued, with brain fog. That can be a lot of things, but one of those things is SIBO. And also weight changes can be seen. And then historically, we've always discussed that you can see nutritional deficiencies, specifically a low vitamin B12 and a high folate. Nowadays, with the attention that we have towards SIBO, ideally we're catching it far before this happens. So you don't see it that often. So what drives the symptoms in SIBO? And the circles came in slightly too early. Bacterial fermentation of carbohydrates. So you eat carbs, right? You eat a piece of bread, you eat some rice, and then you have fermentation into carbon dioxide and hydrogen. And then some of the methanogens, the specific subgroup of bacteria of archaea in your gut, can produce methane. Some acetogens, which is another just group of bacteria, can produce acetate. And then sulfate reducers can produce hydrogen sulfide, and then some can produce ammonia. The ones that are pertinent to this talk are the hydrogen, which is very common with bacteria, the methane, and the hydrogen sulfide. And this is what really drives this, or at least what we believe to drive the symptoms in SIBO, that we think that a lot, especially methane, we think that these can interact with the body, they can have consequences on motility, and also cause a lot of the distension that is seen in a lot of the gas and flatulence. How does the small bowel remain relatively sterile, right? So what is the normal, and why doesn't everybody have SIBO? Why doesn't this happen more commonly? It's because, as Dr. Razai and more than one person already mentioned, it's the housekeeper waves, which generally occur during the fasting phase, and they originate up in the stomach or small bowel. And the way I want you to imagine it, it's sort of like a tide that just keeps everything at bay, right? It's very hard to swim into the ocean if there's a very strong tide that comes in every now and then. And that's how it is normally. But if you lose the migrating motor complexes, you could just float into the ocean. Another way to think about it is that if your intestines are working normally, there should always be a forward force, right? Food goes from up to down. But and it's like, think of as if this man was the gut microbiome. If they try to go up, they shouldn't be able to, because there should always be a propulsive force forward. But if you have hypomotility of the gut, which is slowing down of the gut, then this escalator, if it stops, it's very easy for this man or this metaphorical bacteria to go up the escalator. And that's one mechanism, but we do believe that that's the predominant mechanism. There are a lot of other smaller mechanisms. One of them is stomach acid. But this has the stomach acid, in terms of, obviously that raises a question of, do proton pump inhibitors raise the risk of SIBO? That has been sort of not very well established. The antibacterial activity of the pancreatic excretions. And then finally, the ileocecal valve. And what that is basically it's, the small bowel connects to the large bowel, and there's a bit of a valve there. And ideally, if it's in place and intact, it should act as another barrier against bacteria moving upwards. But in some patients, that becomes the valve becomes weaker or non-existent. Now, what causes SIBO? Now, what has to go wrong aside from that that can contribute to causing SIBO? So SIBO is not really a primary disease, as we've discussed. It's hard for the bacteria to proliferate in and of themselves and decide to grow to that extent. We see it very often in terms of post-surgical patients who have had any surgeries on their bowel, especially ileocecal resection, which is removal of that valve that I mentioned. We definitely see it there. Adhesions which can come in from any abdominal surgery. Oh, I had an appendectomy when I was 10. Oh, I had an ovarian torsion surgery. Any surgery can cause it, but also a lot of times infections that can be pretty bad in the gut can cause adhesions even without having had surgery. Like a very bad bout of appendicitis, for example, very possible for it to cause adhesions even without the surgery. Small bowel dysmotility, as we've discussed, there are some specific reasons to have small bowel dysmotility, such as in connective tissue diseases. You can see it like scleroderma, autoimmune diseases, very common. And then post-infection IBS with the antibodies that were just discussed. Inflammatory, such as patients with Crohn's and then other inflammatory conditions, or patients with history of radiation to their gut. All of those are great reasons to have dysmotility of the gut. Medications such as narcotics, opioids are very common, are a very common cause of slowing down the gut, and it really happens in a dose-response manner. Even patients who say, "Oh, even taking a big dose of opioid doesn't really make me feel different," the effects on the gut, your body does not get used to them. That's why the higher the dose that is needed to control pain, it's still going to affect the gut that much more. And anticholinergics, things like Bentyl and other medications can also contribute to slowing down the gut. Finally, as I said, PPIs is a bit of a question mark, and removal of the stomach can contribute to it, and then chronic pancreatitis as well. Now, how is SIBO diagnosed? There are a few ways. One of them is breath testing, which I believe you may have heard of. Why do we like to do it? One, it's really easy to do. When someone consumes lactulose or glucose, and then you exhale into a machine, and that machine measures the amount of gas that is being produced by the bacteria, which is excreted. Your lungs can take care of removing it from your body. So the machine can read how much gas is being produced by your gut. And what's nice about breath testing is that it can guide the choice of antibiotics. And as we discussed just now, if you have SIBO, we treat that in one way. If you have EMO, we treat it with another set of antibiotics. So it can really help us decide how to treat the patient. Any test, we need the caveat of you can have false negatives and false positives. So nothing's 100%. So it's really hard to grab onto a test and be convinced of the results 100% without any guidance, because there are certain cases that are exceptions to the rule. For example, if someone has very fast gut transit, the lactulose that they consume can reach the large colon very fast, and it's normal for it to be fermented in the large colon. So that can give us a false positive. And this is just an illustration of instead of food, we give you a specific meal of glucose or lactulose. They get to the small bowel, bacteria in the small bowel digest it, release the gas. The gas will cause symptoms maybe, and also will go through the bloodstream to be released in the lungs. And the lungs take care of, they poop the gas out. What's another way to diagnose it? Another way is an upper endoscopy with small bowel aspiration. We don't love to do this because it's more invasive, right? We would have to do the upper endoscopy. If you're getting an upper endoscopy for a different reason, it may be less of an invasive study in and of its own, but just to do an upper endoscopy for this is a bit invasive. It does have the added value of if you have SIBO that's not responding to certain antibiotics, it can really give us through culture, it can give us exactly what the bacteria is sensitive to. So it can help us, figure out, oh, you didn't respond to this antibiotic because your flora is resistant to this antibiotic. We can try this other antibiotic, and it can help us know that. It can also have the added value of diagnosing SIFO, which is fungal overgrowth, because our breath test can't catch SIFO. But on the other hand, it has its negatives, right? Everything has pros and cons. One of the cons is that it can't identify EMO. So we really need the breath test for that diagnosis. And it can be false positive from contamination, and this is very center dependent and technique dependent. But if we're taking the sample and we accidentally touch the mouth, that can be a false positive, for example. And then finally, we don't necessarily do it at our institution, but you may see it in different institutions, especially institutions that don't have access to breath testing easily. They may decide to treat SIBO empirically, saying, hey, I think you have SIBO, let's treat it and see if you get better. It's debatable. Some physicians believe in it, but we don't necessarily think it's the best thing to be done. This is just the reference that we use, which was actually, the first author was the first speaker of today, Dr. Azai, and Dr. Pimentel is there as well. And this is what we use to interpret the BET tests. Now, what are the pillars of SIBO management? And there are 3 big pillars in the management of SIBO. One is that we would like to address the modifiable underlying causes. So fix anything that we can within our limitations. 2 is treating. So you have this overgrowth, you're in a state of overgrowth. We want to knock down the number of bacteria and try to get things more balanced. And then 3, we want to prevent it from happening again, because one thing about SIBO is that it has a very high recurrence rate. So more about 1, in terms of addressing the modifiable underlying causes. If it's opioid related, ideally we can decrease the dose of the opioids, for example, or we can put medications that antagonize opioids specifically at the level of the gut. And if it's related to a certain disease, for example, like IBD, ideally we'd get better control. Or if it's diabetes that's causing dysmotility of the gut, we try to at least prevent it from getting worse and maybe make it get better. So ideally we would have perfect control of the underlying disease, Crohn's, celiac disease, diabetes, anything of the sort that we can control, we try to. And we try to hope to do that before we try to hope to eradicate the SIBO. 2, treatment. The first line of treatment is antibiotics. Antibiotic choices, we have a lot of them. The most common one that you must have heard of is rifaximin, and I think we've mentioned it earlier during this talk. That is one common antibiotic that we use. There are a lot of other antibiotics, but the other antibiotics often have systemic absorption, and we really want to minimize any adverse events that you might get from any medications we give you. That's why we try to go for the smallest gun possible to try to help bridge you to help bridge the patients to better control of the SIBO rather than going for the most broad antibiotics, but sometimes we have to resort to those. And then, so the antibiotics can improve symptoms and normalize breath tests. And for hydrogen sulfide and hydrogen, as I said, it's rifaximin. We could add bismuth to the hydrogen sulfide, as Dr. Pimentel mentioned. Or for the treatment of methane, SIBO, or EMO, I'll let Kokay speak to that in more details. Alternatives, these are just the names of antibiotics that we could use, like ciprofloxacin, trimethoprim sulfamethoxazole, doxycycline, metronidazole, and tetracycline. But again, we don't love to pursue this unless we are convinced that the patient has SIBO and we think that they may have some resistance to the first-line treatment. Another way to induce remission is the elemental diet. Now, what is the elemental diet? It's not some magic formulation. It doesn't necessarily have specific things added to it, but rather it's a diet that's broken down to its most basic components. And what's great about that is that it doesn't have any allergens or any molecules that can trigger disease, and also it doesn't have molecules that we can't break down, like fiber. So when you consume the elemental diet, you don't really need to digest it. It's already broken down to its smallest bits and pieces. All your body needs to do is to absorb it. So when it gets to the beginning of your small gut, you directly begin absorbing it. And ideally, it doesn't reach the end of the small gut even. How does that help SIBO? As you can imagine, in SIBO, if the nutrition doesn't reach the end of the gut, you're not feeding those bacteria. You're not giving them fiber that you can't digest, that they can only feed on. You're sort of depriving them of food. And as you decrease their nutrition while maintaining yours, they're going to reduce in numbers. And that's how it can help with SIBO. Now, another question is SIBO the only disease elemental diet can help? And absolutely not. It can help a lot of other things. Why? Because it doesn't have those allergens. So say someone has celiac disease. It doesn't have gluten in it, so it should help with that. If they have any other illness that is triggered by environmental food, it should not trigger those diseases. Now, what's the catch? One big catch is that it doesn't taste great in general. At least the formulations that are currently in the market, they don't taste great. That is one. And that's really one of the biggest things that we encounter in clinical practice, because we can recommend it, but if it tastes awful, patients are not going to stay on it. And the thing is that you would have to drink it exclusively. And you can't, it's not like you add it onto your normal diet. Now, there is a new formulation that does taste better, but it's not yet available in the market, but it should be soon. And as I said earlier, the recurrence rate of SIBO is very high, unfortunately. Now, how long does it take for someone to have a recurrence of SIBO? It's very variable between one person and another. Some people have actually figured out, I get it every this often. They just sort of get used to it. But ideally, that's not the case. Ideally, we try to treat the SIBO and delay the recurrence as much as we can. How can we delay the recurrence? Roughly half of SIBO patients experience a relapse within a year. I think that's an important number to keep in mind. Diet is a big factor in terms of how we can maintain remission from SIBO and how we can minimize recurrence. Carbs are the primary substrates for bacteria and archaea. But data is lacking in terms of, we don't have rigorous studies in terms of, does this food worsen SIBO? Does this food worsen SIBO? But we have a good idea by now. We know that low carbs diets have been proposed, but more specifically, low fermentation, low FODMAP diet, we have seen success in terms of preventing SIBO recurrence. And the low fermentation diet is very similar to the low FODMAP diet. It is less restrictive, and that is the one we usually favor in our center. The thing about these diets, though, is that we have to be cautious of the long-term side effects of overly restrictive diets, because if you exclude a lot of food groups and the patients have their own restrictions that they don't like this food or that food, so when we end up excluding large proportion of what is sort of healthy diet, but that triggers symptoms in SIBO patients, we have to be very careful about not causing any nutritional deficiencies in patients and making sure that they get an overall balanced diet. Another way to help is meal spacing. And as we mentioned before, and this is based on promoting those migrating motor complexes and making sure your gut motility, we're trying to help it as much as we can. So prolonged fasting, we know that it can promote gut motility through promoting the migrating motor complexes. And one way to help promote this is to try to space out meals and not really snack in between meals. And ideally, it would be for 4.5 hours or more to help trigger them. Another way to try to get more MMCs is to try to fast an applicable way, a pragmatic way, is to try to have dinner relatively early on and not snack before sleeping. That way, while you're sleeping, that does count sort of as fasting time. And that way you can distance the time between meals and promote these motion waves as much as possible. And then we can give medications that are prokinetics, but the data in terms of prospective trial for these medications are limited. So we don't have rigorous clinical studies that support these, but we have seen some success with them. Prokinetics, there are a few that are available to us. They include low-dose erythromycin and prucalopride. But the patients that benefit from these prokinetics are highly selected patients. So it's not that anybody who's ever had SIBO should be on a prokinetic. And then in terms of future directions, there is some data to suggest that maybe statins can help reduce the microbial overgrowth, specifically with EMO. And maybe supplements like algae extract are being studied to see if they can help control these microbial populations. But the data is still not there. So we can't really recommend it, especially not broadly. And a lot of these will end up being very patient-specific. And as we've discussed earlier today, the microbiome connection is a great way to learn more about things that we glance over today, specifically the diet and the reasoning behind the fasting periods, this is a great resource for you to learn more about these. So what are the take-home messages? SIBO and EMO represent an overgrowth of normal gut flora in an abnormal way, and that makes it abnormal, and that's what causes the symptoms. Symptoms are many and include diarrhea, constipation, and distension. Diagnosis can be made by using breath testing or small bowel aspiration. Treatment is usually with antibiotics and differs between SIBO and EMO and SIFO. And the elemental diet is an option for certain situations. It's not necessarily for everybody. And recurrence is common. It should be expected, but we should try to work as much as we can to minimize the recurrence. And prevention can be attempted by dietary modifications and certain medications. And that's it for my talk.